what I'll do is I'll introduce each person before I ask them a question, so you get to know who they are and where they work. And they'll give us a bit of a chat. It's kind of a discussion forum, so it's designed to be participatory, which means you as the viewer, and not just a viewer, but somebody engaging in this as a discussion, like a roundtable. So you might see at the bottom of your screen there, however you're looking at this, there's a Q&A function. We would like you to write any questions that you have in that, not in the chat function, but in the Q&A function, so that we can run this like a Q&A forum. And then our speakers tonight will be able to address those questions either by writing responses to you or by talking to those as we go along. So any questions that come to your mind or any thoughts that you have as we progress, please use that Q&A function. It's going to be essential for us in terms of getting feedback from you and being able to answer your questions before we finish. Anyway, you didn't come here to listen to me waffle on and talk all night, because there are people on this panel who are experts in their field and have great insights to share with us all and to answer your questions. I'm going to jump to introducing our first panelist this evening, which is Carla Treloar. So Carla is a Scientia Professor and Director of the Centre for Social Research in Health and the Social Policy Research Centre at the University of New South Wales in Sydney. Welcome, Carla. So you've got a nice background there.
Yeah, lovely La Perouse.
There you go. So the opening question for you, which may be familiar to some of the people tuning in tonight, but for others, this may be, the starting point for them learning about what we're going to talk about tonight, is what is social research? If you can define that for us, Carla.
Sure, nice, easy kick-off question. Thank you. This is, something that people might have their own opinions of on the panel of my esteemed colleagues and in the audience. So really interested to hear what other people think. But it might also be useful to start with what social research is not. And social research really avoids trying to think of individuals as these rational, autonomous beings that kind of circulate around each other in space, and that we only need to understand what's going on inside someone's head and we'll have the answers to everything. Social research really likes to blow all that up in terms of thinking about, if we're taking the example of condom use or PrEP or use of sterile equipment for injecting or taking ART, is how all of those things situate themselves in relation to others. In terms of bloodborne virus transmission, we need at least one other person to be there. But then also, what are the relations? What are the relations of power or status or gender or other things that shape how people interact with each other? Where are they? What are the spatial settings in which people are doing these things? What are the layering on top of that? What are the things of economics, both macro and micro, that are influencing what's happening? What's the legal histories? What's the issues of politics and legal and media? How do all of those things come together so that we can understand what's the best way forward to try to achieve a mutually agreeable goal? How do we bring knowledges, diverse knowledges, and especially and essentially community knowledges into that mix so that we can produce something to get to that goal? Because I think the thing that social research is trying to do is put the flesh on the bones of epidemiology or clinical research, and that flesh is multiple and messy and sticky and wonderful in all its complexity, and we want to use all of that knowledge that we can possibly grab onto to produce stuff which does good things. Because I think social research is very aware that not only are we trying to do good things, it would be a terrible waste of money and everybody's time if we did something that wasn't effective. But we are also very aware that what we could do could have very harmful effects for people who might have least power or who hold very marginal positions in society. And so by potentially ignoring all that stuff of politics, legal, media, history, we run the risk of doing something very harmful, not just ineffective. So we want as social researchers to try and gather those things together in ways that are useful and understandable for our wide range of community and other colleagues that we work with to produce something that's effective and empowering.
Thanks, Carla. That was a great definition of social research. I like the meat on the bones and the kind of meaning of that in terms of without the social research, some of the data as it sits alone, the clinical data or otherwise just might be bare bones and not actually tell the full story. But the meat on the bones comes from that complexity around that social research helps answer and fill in the gaps on. I've got another question for somebody from Sydney who, unfortunately for you, are in lockdown tonight. Another UNSW person who is very well known to us all. Martin Holt. Hi, Martin. How are you?
I'm good. Glad to be here, Chad.
So, for everybody, Martin is a professor at the Centre in Social Research and Health at UNSW in Sydney. He specialises in HIV prevention research with gay and bisexual men and leads the well-known gay community periodic surveys. So, Martin, my question for you is, how does social research work with clinical research? How do they work together?
Yeah, thanks, Chad. And this follows on a bit from what Carla was saying about looking at other things. And there are two parts to this. I think people tend to understand that clinical research is often testing something to see if something works, like a vaccine or a treatment or an intervention or a health service delivery. And it usually has very clinical research, because of that, is fairly rigorously designed to look at fairly limited outcomes. That's the whole point. It's like tightly controlled, so they can tell us with confidence at the end whether something works or not, whether it's safe or not. Of course, in doing that, it tends to neglect by design almost everything else that might matter to the people involved, including the service providers, but most importantly, the patients. And so I think social research that's done in collaboration with clinical research is often focused on patient experience, maybe more broadly the culture of the clinic or the service that's undertaking an intervention, the experience of being on a trial for a drug or something else. But also that messy stuff, that contextual stuff that that helps an intervention work or actually prevents it from working. And to give an example, I was reflecting on this earlier when I saw the list of questions. I was thinking about changes in the way that sexual health testing and screening is done for many of the populations that we work with, and what's counted as best practice. So providing a supportive environment, being non-judgmental, getting a sexual history, putting someone at ease, making sure all the right tests are done and so on. And that if someone's diagnosed with something like an STI, like chlamydia or something common, they get an effective course of treatment and an appointment is made. Now, from a clinician perspective, if all of those things are done, best practice and the patient seems reasonably comfortable, best practice has been met. However, I know from qualitative research that I've done and some of my colleagues have done, if you speak to someone who's gone for sexual health screening, gone through that procedure, they'll say the doctor was fine and all the rest of it, but they get diagnosed with an STI. So they're diagnosed with something and given a course of antibiotics. They may go away feeling ashamed and uncomfortable. They might feel they've done something wrong, and they're too embarrassed to say that in the consultation. And from the clinician would never know that unless you've done social research about the patient experience in a safe setting outside. And clinicians love knowing that kind of stuff. So in intervention research, often having this kind of outside or nested research to provide perspective on how the interventional trial is going or how something is being received is vital in terms of understanding and tweaking patient experience and delivery. The other thing is actually independent social research. So we often rely on clinically collected data to assess programs. How many people are coming forward for testing? How much treatment are we delivering at the moment? Vaccine rollout. But the clinic collected data, because clinics are busy places, tends to often be quite limited. And then it raises more questions, like if there are gaps and you think, well, why are some groups coming forward and not others? Having socially and community-based research is often really important to understand particularly the people that don't come forward to services. So clinic data by necessity is biased towards people who turn up at services and misses other people who avoid going. So those are two kind of obvious reasons why social research is important, I think.
Thanks, Martin. And it's a good lead into my next question for another speaker in terms of engagement with community, because as you just highlighted from your example, sometimes the way that the social research is done to reach out and I guess recruit people or gather data or input from people leave some people out of the process. So my next question is going to go to somebody a little bit closer to home down here in Victoria with myself, and that is Adam Bourne. Hi, Adam, how are you?
Hey, Jad, I'm good. How are you?
Good, thank you. For those who haven't had the privilege of meeting Adam, Adam is an Associate Professor of Public Health and Deputy Director of the Australian Research Centre in Sex, Health and Society at La Trobe University in Melbourne. He has spent the last 15 years working in HIV social and behavioural research with projects spanning Europe, Southern Africa and Southeast Asia. He is a member of the Victorian LGBTIQ Whole of Government Task Force and is also on the board of directors for Thorn Harbour Health, who are hosting this session tonight. Well, Adam, here's my question. What are the mechanisms for community involvement in the design of social research?
Multiple, I think, is the answer, Chad, both formal and informal. I think the reality is that research itself is designed in a whole range of different ways. And so there's lots of then different ways in which you can influence the design of that kind of social research. There's different points at which you can influence the process. Often what we do is what we have a tendency of calling investigator-driven research, by which I mean it's researchers themselves who come up with the idea for a project. They design it, or at least the bare bones of it, and they shop that around to different kinds of funders to help make it a reality. They pitch the idea to people like the Australian Research Council, the National Health and Medical Research Council. But those ideas themselves, those pitches to these funding bodies, those ideas come from all manner of different places. Sometimes it's we review the existing literature on a given topic. We look at what other colleagues, other researchers have written, what they've already identified. And we think about, okay, well, what are the gaps? What do we not know on the basis of what's there currently? What further do we really need to know to kind of advance our understanding of this particular phenomenon? Sometimes we craft or design studies in response to government initiatives, to government policies or strategies. We look for what governments might be seeking to accomplish in relation to HIV. And we look and we think about, okay, well, what evidence is required or what new knowledge is required to inform that, that framework to ensure the implementation of that policy. And sometimes the ideas that we pitch for funding come from conferences, they come from seminars, they come from events just like this one. Some of the best ideas I think I've certainly had in my career have been in speaking at events, being asked questions by audience members, formally putting their hand up, or even informally in over coffee discussions that happens afterwards. How can you explain this finding? Why does this difference between X and Y exist here? And it's those why questions that I think social research is particularly adept at trying to answer, and we're I think often particularly interested in. So sometimes it's so that I guess my point here was that one of the key mechanisms for community involvement in research is exactly these kinds of forums. It's people showing up, it's people expressing interest, it's people asking questions of researchers and of our community partners, asking questions of Thorn Harbour or ACON, for example. This helps us in turn craft the right kinds of research questions and the right kind of pitches for funding. So there's a kind of very informal way in which it happens. I guess in slightly more formal mechanisms, perhaps then if you think the funding has been secured, there are other ways in which we work with community to craft the design of the studies. I think probably all of my colleagues on this panel And I think we're all similar in typically convening community advisory boards for each of the projects that we operate. Most often these are made up of members. The members of these boards are made up of representatives from community organizations, but sometimes it's kind of Joe and Jane public, like members of the general population with lived experience of the topic as well. And these kinds of community advisory boards are really crucial in helping us attend to the nuance of a research study. So we might have the big picture idea worked out, but these advisory boards help us think through what exactly is it we're trying to assess or ask about here? Who exactly is it that we're asking? How are we asking them in an ethical and a sensitive way? How do we ensure diversity in our samples? How do we interpret and explain some of the findings? How do we articulate them in a kind of reasoned, evidence-based, sensitive and ethical manner as well? Those are all really, really crucial to the success of a project. And then the kind of third and final key mechanism that I had in mind is through formal community endorsement. So both Thorn Harbour and ACON have formally constituted committees that are tasked with reviewing proposals from researchers. And they have policies that say they won't promote a study unless it has been reviewed and endorsed by these panels that exist within the organizations. They're in-house committees. They look at the things being proposed by researchers, and they ask questions. Is the language of the study inclusive? Is it affirming? Is it non-stigmatizing? Is it, are we asking the right kinds of questions? And so that's the kind of third key formal mechanism. So those were the kind of three mechanisms I thought of, really. The kind of informal asking questions and making us think, participating in community advisory boards, and then formal community endorsement panels.
Yeah, thanks, Adam. And I think that's part of this series, revisiting and focusing a spotlight back on research and HIV, because, research in HIV has been going for many, many years now and continues, but we need to check in and make sure that we're doing it in the best way possible and really getting that meaningful involvement of the community. And community advisory boards and those endorsement committees, they're a good way of doing that. Maybe there are other ways that we can discover through these forums and discussions as well, or ways that we can overcome jurisdictions in Australia where you have one system in New South Wales, for example, and one in Victoria. Maybe there's a better way of doing something nationally. Let's get that discussion going and seeing how we can improve it for the researchers, but also for the community in terms of the outcomes. But as you said, one of the key things was the coffee chat questions that pop up at a conference or wherever else. And since we can't come together necessarily at the moment to have that conference, these forums are what we've got. So thereby I encourage everybody who's here tonight to ask that coffee question of our panelists in the Q&A chat part, because that's what we're here for, is to give you an opportunity to learn, to inquire of the great minds that we have before us, because it's going to be very rare that you get a panel like this if you're a social researcher or a budding social researcher and you want to hear from some mentors in the sector. You've got them all here on the screen tonight, so far away with the questions. I see some coming through, and I think some of our panelists are starting to answer those in the chat as well. Ben Bavington, also in Sydney, I assume that's where you are, stuck locked down. Sorry to hear that, if that's where you are. How are you, Ben?
I'm actually in Canberra right now, so I'm not actually locked down.
Oh, there you go. You escaped.
It is still a little bit restrictive.
All right. For those who don't know Ben, which I would find surprising, but Ben has worked in the field of HIV prevention and research for over 15 years in Australia and internationally. He's a research fellow at the Kirby Institute in UNSW, focusing on the biomedical, behavioural and epidemiological aspects of HIV prevention among gay and bisexual men in Australia, but also in the Asia Pacific region. So as we dig down into some detail and some examples, Ben, my question for you is, what particular studies, in your opinion, have really changed the ways that we think about HIV community?
Yeah, thanks, Chad. So I'll preface this just by saying a bit of a caveat that this is obviously just my opinion, and I don't know the details of every study that's out there. So just to put that out there. And rather than going all the way back in time about like mentioning some of those really important, formative, particularly social research studies from say the 90s, even the 80s or the 2000s, I'll try to focus just really on the last sort of 10 years because I think that's the more recent period that's probably a little bit more interesting. So I think there's two levels, I guess, here. You've sort of asked about what studies have changed how we see HIV in the community. So there's kind of a couple levels that I'll talk about here. One level would be the kinds of studies that the community actually knows about. They're kind of famous studies. People know the name. They're kind of a huge number of people participate in them, those kinds of studies, versus the ones that might have had a lot of impact behind the scenes. So things that could have been going on for quite a long time, or maybe just a once-off study that just happens. It could even be something small, like a qualitative study, but then that actually has quite a lot of policy and programmatic impact behind the scenes. So I think it's important just to note that there are those kind of two levels. So this is, again, is just my opinion, and this might be different from some of the other panelists because I may be the wrong person to have thrown this question to, Chad, because I'm probably a socio-behavioral researcher, sometimes an epidemiologist rather than an actual social researcher. But what I would say is that over the last 10 years, I think the biggest changes to how HIV is thought about in our community have probably come more from the biomedical studies than from the social studies, because this has been a pretty wild 10 years for biomedical research, starting in 2010 with IPREX, moving into HP 10052, then into the other studies proving treatment as prevention, the giant PrEP rollout studies that happened across Australia. And so I think they're the ones that have really changed our understandings of HIV and really transformed the way we deal with HIV. However, as both Carla and Martin have both said, all of those studies involved at least some elements of socio-behavioral data collection. I mean, everything that we do in Australia pretty much has multiple levels, ranging often from the qualitative through to the behavioral, the social, then perhaps into the clinical and epidemiology. A lot of our studies actually do all of those things all at the same time. And I think that's actually true of the big studies, for example, that we've had here, like Opposites Attract or EPIC or PrEP-X. There's been this kind of, they're not just epidemiological or clinical studies, they're also got a social or behavioral or qualitative element to them. So I think it's both of those aspects that have been quite impactful on understandings of HIV in the community, even from those big biomedical studies. But there's also been really big impacts from more socio-behavioral research as well that don't have a clinical or epidemiological component. And so I'll just mention some of these. I don't want to offend anybody, particularly on the panel, by leaving something off that's really important to them, but I'll just mention a few that I think are really key to me. So a really important one that's already been mentioned is the Gay Community Periodic Surveys. So this has been running from 1996. We are lucky to be one of the only countries that have had such good data collection every single year since, over 20 years now, that really look at men's behaviors, how they relate to each other, their practices in sex, drug use, PrEP. We incorporated biomedical prevention into that in the sort of early 2010s and have continued updating that. These surveys now are just referenced all the time, and we are constantly asked to provide analyses for various policymakers or community-based organizations or programmatic areas because they not only allow us to look back in time, but even though they're quite short, they allow really a rich understanding of what's going on, even though they are sort of superficial at the same time. So it's quite interesting there. We've recently, for example, documented that PrEP has overtaken condoms as the most commonly used HIV prevention tool for casual sex. And I think that's a really key finding that has had big implications more behind the scenes in terms of policy and practice. Another couple of really important ones recently are some small qualitative studies that have been getting run both in Sydney and in Melbourne, really focusing on this issue of cultural and linguistic diversity, overseas born, people who are born in Asia, and their experiences of the HIV response here in Australia. So we've done one out of Sydney. There's a couple happening in Melbourne run by Jason Zong's team at the Melbourne Sexual Health Centre. And again, I think these data have been so incredibly important because alongside big studies like Carla's stigma indicators monitor, or whatever it's called, the monitoring of stigma project that happens nationally, these qualitative studies really have given us this understanding of how stigma permutates these people's lives in a really real way, the stories that they tell and the kinds of reasons why they might not present for testing or why they might not know about PrEP, and the way that stigma really feeds into that. So I think it's a really, really great adjunct to that really important work that Carla's doing on sort of mapping stigma at the kind of quantitative level across various different populations. And I think there is some qualitative components to that as well. So I think that's really important too. The PREPARE study is another one that people, again, might not know by name out in the community, but I think the results of that study, it's been going since 2011, every 2 years, we've had like this updated data about gay men's attitudes, gay and bisexual men's attitudes, about biomedical prevention, including PrEP and treatment as prevention. So these have been really, again, important, an important study that's given findings that have influenced a lot of policy and practice. And there's so many other studies to mention, but another really important one coming out of course, La Trobe is the HIV Futures. And in a similar way, we're up to number 10. This has been going for a really long time. And I think the data that have come out of that study to show what's sort of going on in the people living with HIV communities around Australia has been really, really important. So like I said, not all community members would know the names of these studies, but everything that I've mentioned here and a whole bunch more really have impacted the development of HIV strategies, different kinds of policies, funding decisions, and the way that programs get run, including in community-based organizations. So I'll leave it there, but I'd be interested in what the other panelists think if I've left something out. Thank you.
Thanks, Ben. And yeah, probably a hard question to ask in front of all the peers in the sector in terms of making sure that you highlight the work of the other people present. I think you did a pretty good job of going around the table in terms of some studies that your fellow panelists have been involved with for a long time, including yourself. I also like the way that you highlight that social research doesn't stand alone. And, you know, often a research study, one particular protocol is biomedical, clinical, social, epidemiological, and more all in one study. So it's not something that just sits out there isolated from the rest. So if you want to put the meat on the bones, to come back to Carla's, you know, comment at the beginning, the meat and the bones are connected. They're often one and the same, and they come together. Good to see some questions coming along in the chat, and thanks to the panelists for also addressing those. I'm going to introduce our final panelist for the evening, Jennifer Power. Hey, Jen.
Ted.
So for those who haven't met Jen is an associate professor and principal research fellow at the Australian Research Centre in Sex, Health and Society at La Trobe. Jennifer is a sociologist who specialises in research related to sexuality and sexual health, and currently manages the major HIV Futures study that we've just heard mentioned. My question for you, Jen: community participation in social research is critical to its success. How do you get the community motivated to participate? This is a big question.
Thanks, Chad. I've got lots of answers.
Good.
But would also actually like to hear from community on that one too. But listen, at all these forums, and you might have heard me say it before, but I do like to bang on about it. I think it's important to remember how profound the social research has been in Australia around in response to HIV. So public health research has a long history of quite sort of medicalised, individualised approaches to understanding human interaction and human behaviour and human decisions. As Carla was saying, that kind of, you know, individual rational actor that operates in the world. But HIV came along and we suddenly had a bunch of research that applied this political lens, this cultural lens, this community lens, like this social lens to public health research. And it had a profound impact on health promotion, on the way we actually understood how to respond to HIV. And I think, like, I know you're looking at past, future and past, current, present and future next forum, but it just might be something worth remembering how profound that's been in terms of the way we approach public health research internationally, actually. And Australia's really led the way here for lots of reasons. That's some other day. But also fundamental to that has been community, like community participation, the extent to which researchers have been actively part of community. So, the overlap, the LGBT queer community members who are researchers, but also just the way ways we've developed these really excellent partnerships in Australia, you know, and it's not all, you know, it's been up and down and it's not always worked really well. But one thing I've definitely noticed when I've spoken to researchers overseas is the way they, I mean, people comment on the way in which we all know each other, we talk to each other, we have these kinds of forums, people show up at these forums. So interaction between community and research in Australia actually is world leading. And I think we should bang on about that more and talk about that more and document that more, because it's really important. Sorry, that wasn't what I was going to say. So I'll go back to what I was going to say. I do think, you know, how do we get community to participate? Actually, in some ways, I think it's really about where we start from and the ways in which we value community knowledge and community expertise, as well as community participation. So often in research, you know, we can sort of approach this, that's not so not bad-mouthing researchers, but I do think sometimes we think of community participation as kind of endorsement, you know, at a political level or ethical level, or recruitment, assistance with recruitment. But in actual fact, really good participation, really good meaningful participation of community is about actually the experience and the insight and the expertise of community bringing data to life. So actually helping us shape the questions that we ask, the way in which we ask questions, the questions we ask of community in social research surveys or interviews, and then the way we look at the data and make sense of data. And there's some great examples of that, which Ben's mentioned. Actually, I think Martin's studies, the gay community periodic surveys, are a really good example of a survey that relies on knowledge of the social and the sexual cultures of gay and bisexual, bi+ men in Australia. So, you know, it requires understanding of the places where community gathers, the places where sex happens, the spaces, what those spaces are like, understanding of cultural practices, of social practices, of sexual practices within that cultural and social environment, you know, the culture and the actual physical spaces. And this is community knowledge. This has come through understanding community, through speaking to people, through the coffee breaks at conferences. You know, it's community insight that actually shapes that study, and it's what makes sense of the data. So that study doesn't happen without community. Even though it's a quant survey, it relies on formal quantitative social research methods and rigor. Actually, community insight's fundamental. And HIV Futures as well, that's a survey that we do, again, quantitative methods, people, you know, fill in their surveys online, but actually we spend a lot of time paying attention to what issues are kind of circulating, what people are talking about. And it wouldn't make sense to run that study without that, you know, without sort of understanding what's meaningful to community at the time. And there's one example I can think of actually where community have really helped me, I guess, make sense of that data. So in Futures, we continually get these different outcomes for people living in South Australia. So in South Australia, there tends to be poorer well-being among people living with HIV. There's a lot more poverty. There's a lot of people just not doing as well. And I didn't have an in to South Australia to kind of understand that. But once I started speaking to people about the history of the HIV sector and service delivery in South Australia and about some of the communities affected in South Australia, it just gave me insight that I didn't have just looking at the data. So meat on the bones, as Carla said again. So I guess my answer to that question is really, it's not about clever ways to get people to participate. It's actually really genuinely understanding what different forms of insight and expertise bring to a research study, and then building partnerships that make the most of that. So it's really, well, I've said this again lots of times, I feel like I'm repeating myself. I actually think the long-term partnerships that we've developed in Australia are really key to that. So it's not just about gathering for one project or a 6-month period. It's actually about the conversations that a lot of us have had for many, many years. And we know each other, we know what people are working on, we know what people's kind of the projects they've worked on in the past, and it's quite easy to pick up the phone and just, you know, get a sense of what someone thinks about an idea or develop something in informal consultation. So the kind of pitches that Adam was talking about that we might take to a funder actually have probably happened because of this kind of ongoing, chats and discussions and informal collaboration that we have developed really well in this sector. we should totally patent it because it's really good the way we do it here. But I also think that to make that happen, to manufacture that, requires responsibility at the organisational levels. So at the level of Arches or the Centre for Social Research and Health, as well as at the community organisation level, because individual researchers carry it a long way, but actually, you know, we aren't always here. Contracts don't always get renewed. People move to other jobs, you know, things turn over. And if organisations, the leadership of organisations understand that, they build in mentorship, they build in the importance of community partnerships into the way we work, you know, people have been there for a long time and new researchers, and also community, then it can be sustained. And also I just noticed a question on the screen that's moved on now. Sorry, I'm not sure if everyone can read it, so I'll just repeat that. But there was a question about how do we respond when research isn't taken well by community. So if there are results that community might be uncomfortable with. And I actually think community partnerships are really key to that as well, because actually it's a partnership in interpreting the findings and speaking to community about those findings. So the example given on the screen was an association between increased STIs among PrEP users. And, you know, what does that then mean for potential stigma or the way in which we understand PrEP in relation to STIs? You know, it may not have been taken well, but actually the conversations that we have with the community, the role that an organisation like Thorn Harbour plays in actually making sense of that and finding a way forward with community and looking at what that really means for health promotion. That's how we respond to that. The partnerships are actually key to that as well. Thanks, Chad.
Thanks, Jen. I really like the way you painted that picture, both in terms of the engagement between researchers and community is not this polarized thing where you have researchers over here and community over there, but in Australia, it's a blend where some researchers are from community, some community members are researchers, and researchers and community members are friends and colleagues and know each other really well. So it's kind of like, in my mind, more like a Venn diagram than it is like, you know, two kind of groups that have to occasionally pick up the phone and talk to each other. But it's a mesh, and that's the way it should be. And I also like the way you paint the picture in terms of chronology and time. It's not like, okay, now we need to contact community because we're going to start this project and we've got some funding from NHMRC or whoever for this period of time, so let's engage. But even perhaps when you're not doing a particular piece, you keep that relationship going because it's a relationship that spanned decades and something that is growing and being dynamic and forming. So it's thank you for the way that you sort of framed that reality that we have in Australia. And I guess we're blessed to have that here. And it's because of the active engagement of community, but also because research in Australia, I think, have mostly been respectful of community and done that collaboration in a true and meaningful way. Carla, I'm going to jump back to you with a question about when you're designing a study, what kind of ethical considerations would you need to be thinking about?
Yeah, so, you know, every project, every researcher, we've got to jump through the hoops of gaining ethics approval. And, you know, unfortunately, they tend to be rather formulaic experiences and don't really deal or get into the juicy stuff of what this research actually means, and particularly in a political sense. Or in, and it was raised in one of the Q&A questions about the potential harm to community as a result of doing this or a result of publicising research. So a couple of examples to pull this up. You know, it's been mentioned we run the stigma indicators monitoring project. So we're measuring the experience of stigma in a number of priority groups, including men of sex with men, people with HIV, people who inject drugs, people with Hep C. And, you know, when we present these data, there's very often the question, and what was the internalized stigma? People really are interested in that. And it's a very important component of stigma to understand. However, we've had really strong pushback from some of our community partners about the individual cost of answering those questions, because the questions on the page are things like, I feel worthless because of my whatever attribute we're measuring. I feel dirty, I feel unclean, I'm not good enough, or I'm not as good as other people. And, you know, I think that's a political question of, do we need to ask those types of things each time? To what value are we extracting it? What is the cost to the individual of producing that? I think there's other examples of this, the political ethics, to frame it that way. You know, I think our research has underdone research with trans people. It's underdone research with people who are not white and don't speak English as a first language. And that's and of course with Aboriginal and Torres Strait Islander people. So that's a really big P, big E political ethics to get our head around. And then I think also that one of the issues raised in the Q&A is about media. And, you know, for the last couple of years, I've also been working in social policy, so poverty and material disadvantage. And it is so much easier to do media work about that. 3.2 million people live in poverty, of which 750,000 people are children. It's such an easy media sell. To be able to go and do the same for my work in drug use or Hep C or HIV and be sex positive and drug positive, it's the risk of that blowing up, not just for myself, though I know people on the panel have experienced really difficult situations with media attacks around the work that we do, but for the community and for the larger effort of trying to make that better positive change. And, you know, this is not, so I don't tend to do media around the research in Hep C injecting drug use unless I have complete control of that. And when in the world do we ever have complete control of what will happen in a public space? I've got a project starting in a couple of months. This is a bit of a teaser that is likely to hit every right-wing media outlet with a massive explosion. So, you know, watch for that. It is so fraught and so hard to walk into these spaces and do justice to the position you want to take without causing harm for yourself, your colleagues, community, and for the big project of getting stuff done well in terms of policy change or practice change. So they're the, you know, we don't write that on the form that goes to the University Ethics Committee, none of that. But I think it is part of the process of being long experienced in this field, having deep community partnerships to help us tease this crap out and forecast where things could go wrong and develop strategies or, you know, ways that we might be able to rescue things if things really do turn dark.
Thanks, Carla. You know, it makes me ponder the way you describe it, and so true in terms of there's the formality of getting the ethics approval before you start the study. But that can be a tick box in some regards. And yes, you do it properly, but there's so much more depth and nuance to what ethically happens after that and beyond the study and through the dissemination, which you can't possibly ponder necessarily at that point when you're filling in the form for your committee. So waiting with anticipation for your new study to come out, whatever that may be, but the community and researchers behind you as you take that forward. You also started to take the conversation in directions that are both answering what people are asking in the chat, but also where I wanted to kind of go as well, is that, you know, we've been doing research on HIV in Australia for a long time now, decades. Is there anything, and it's an interesting question for researchers because it questions the validity of your careers, I guess, but it's kind of like, well, what's next? Is there anything still left to answer? Have we not answered everything that we know or we need to know already? What is left unanswered and what do we need to be focusing on? I'm going to ask you first, Martin, but I'm quite happy for any of the panelists to jump in on this as well.
Yeah, thanks, Chad. Obviously, all researchers will say, yes, of course, there are questions that remain unanswered and we don't get paid enough, we don't get enough funding to do anything. I think community organisations would say something similar around not having enough to do. But I think there's a really, we've been talking a bit about recent change, particularly in HIV, but also in viral hepatitis. There's been huge technological change in the last 15 years, which is massively disruptive, which has presented huge opportunity. And we've seen massive change in the practices of some affected communities in terms of treatment or prevention methods, and what is considered acceptable, what's considered the most desirable or acceptable forms of prevention, and so on. And we wouldn't have known that was happening unless we'd invested in tracking that and understanding what was going on. But also, now and some of the Q&A has been around this, around underserved and marginalized populations, people who might, groups that may get left behind, who are traditionally left behind actually in health research and in health systems and outcomes. And I think there's been a really interesting parallel to improvements in HIV prevention, treatment, and testing and engagement, for example, in the last 10 or 15 years, where it's actually shown that the success story of the Australian response, which we're very fond of rehearsing, particularly for our political funders, actually we've actually become so successful in the most recent period that it's actually revealed there are a variety of groups who are left behind, where it's actually quite difficult engaging dispersed, marginalized populations who have very good reasons of being suspicious of health services, of coming forward to well-established organizations, who don't have easy access to services, who don't feel confident practicing prevention, who are worried about their visa status or don't have Medicare, and so on and so forth. And those issues don't get solved, immediately. I suppose, so some focused attention there, and practicing the principles we've talked about in actually seriously listening to people. But actually, I was reflecting on it, like some of the questions are around who's left behind, and the history of, say, particularly LGBTQ people being involved in research, particularly in the HIV space. But now there's a debate where, like, we're focusing on multicultural populations and heterosexual people at risk of HIV and so on, migrant groups. We might need some different faces to be involved here, and some different representation, which is easy for me to say as a white cis gay man who's built his career working in partnership with community. But you can see now that I don't have legitimacy working with some of these populations, and I was replying to some of Craig's questions online about working in partnership, where you actually need different partners and you need different access and you need to learn new ways of working. But I suppose in the more kind of optimistic part of me is we can actually see that there's going to continue to be innovation and change in services, technology, delivery that might be brought in to try and deal with some of these problems of engagement. So more remote methods, telehealth, different modes of delivering prevention, treatment in different forms. And with each of those, you need to know whether it's acceptable, whether it's actually meeting the concerns that you've identified in previous research, how it's being, and the thing that fascinates me is how it's often used in unintended and unexpected ways. So for me, the thing that was really fascinating about HIV social behavioural research in particular is that all the way through, yeah, sure, it's had an instrumental aim, which is like, are we doing the right thing? Are we seeing gains in prevention, testing, treatment, and so on? But often it's revealed that the things being offered to the community were not what was required, or it's not being offered in the way that's needed. And then often, and even more interestingly, that things get taken up and used in different ways by a community in terms of their identity, how they understand themselves, the practices they negotiate with their partners. And I think the thing that we often forget, because we have a fantastic research response, particularly in HIV and in viral hepatitis in Australia, but the vast majority of people's practices are invisible to us all the time and will remain so. We're not there in everybody's private lives or with their partners or with their families or with their friends or at home. Research only captures a really tiny bit. If it's well designed, it captures some of the good stuff that we really need to know about. But the vast majority of the time, we're behind what's happening in the community and we're playing catch up. So if we're lucky, if we work in partnership, if we consult widely, if based on our expertise, we can project forward, we can think of some important things to follow and track. And if we get it right, that helps the response, it helps the community, it helps us carry on. But I often remind myself that we often don't know half of what's going on most of the time. And remember, having that humility, at least for me, kind of keeps you keen, like it keeps you keen and keeps your brain working, rather than thinking that we know it all and that the data speak for themselves or whatever.
Thanks, Martin. We've answered the question for me that there's still work to be done. It really is about who's not at the table, I guess, from what I'm hearing from yourself and the other panelists. As the demographics in Australia change, as the face of the epidemic and the face of HIV changes in Australia, and perhaps there needs to be different people at the table who traditionally we haven't engaged with, or when we engage through the formal community organisations, they don't have that reach that we're looking for. I guess the question for the panel is, how do we make those people feel comfortable to come and to give that information in social research, which is often so personal and often taboo for people from different cultures to even talk about it, but let alone answer questions with somebody they don't know about it. Jennifer, from your experience, you have any thoughts about how we can do it better, how we can get those people who are missing from the table to engage with us as researchers as we go forward?
Yes and no. I've got some thoughts, but no definitive answers, which is the issue, right? None of us entirely do. But I do think this is, again, a place where we need to think collectively. Like, in a way, social researchers can't reach people that you can't reach necessarily as community organisations. So it's something that I think we need to sort of collectively work together on, how we actually reach beyond the networks of people who are already engaged with HIV services. And research can do that to a certain extent, but we actually rely on partnerships to do that. So again, just to go back to my point, I do think it's about meaningful engagement with communities. And picking up on what Martin said, I think we need to think about ways to look beyond our existing networks, which isn't necessarily an easy thing to do. Like it worked when it came to sort of focusing on LGBTQA+ community, because we had those networks. It's a defined community. It's people, it's people that we have a long history of working with. But in Australia, what we're talking about when we're looking at people who are born overseas are people with a really diverse experience in terms of migration. So we've got international students, we've got refugees, long-term migrants, second-generation migrants in some cases. So a real diversity of experience there, as well as a diversity of cultures and languages. And then if you layer gender, sexuality on top of that, how do we meaningfully engage with such a diverse range of communities? And that's not to throw, I'm not throwing my hands up saying it's too hard. I think that's the question, and it's an important question. Martin's point just made about we need some different faces around the table, I think is really important. So I do think actually building the workforce in research as well as in community is going to be key to that. And I've noticed that shifting actually, just in the last few years. I think the community sector has really been able to bring some new faces, new people on board who have different networks. And that's actually, being able to open the door for some more social research in that space. So I do think it's shifting. It's just a slow process, which brings me to my second point, is that it is a slow process. Like in research and often in projects, who funders tend to think in small timeframes. I'm sure everyone here gets funding in 6 months, 12 months, 3 months, 3-year blocks. If we get a 5-year block of funding, it's like a permanent job. Like it's just unheard of. So yet to actually build relationships, long-term working relationships with a range of different communities, that takes time. And I think we do need to think more strategically about that. And the best example I think we have is the work that is done with Aboriginal and Torres Strait Islanders communities in Australia. I think we as researchers, certainly have a better understanding of the fact that you can't just turn up and say, I've got a 6-month contract, work with me. Never met me before, I'm a white fella, just work with me. It doesn't work, and it's not fair, and it's not okay. Actually, you need to invest in very long-term relationship building and trust building with communities. So as a sector, community and research, I think we just need to start thinking a little bit more carefully about how to build that long-term planning into this research and into these networks, and also what it means to respond to what communities are telling us. And again, you know, for research, this is where our partnerships are really key, because we don't want to do research and then say, well, this is what we found, and not necessarily have anyone to follow up on that. And the thing that comes to mind for me at the moment is what some of this early research has with people who are born overseas, people living with HIV who are born overseas, has started to point to, is people's incredible anxiety about their visa status. And what it means to get a health waiver, and who can help with that. And as the sector's possibly quite well placed to help with that. So I think if we're actually forming good partnerships between research, which is showing this, and community who potentially can build a program and service level response to that, that's when we'll start to see people coming, you know, understanding what research means and feeling more comfortable potentially participating. I could be wrong, but I do think actually being prepared to respond, like we have to be prepared to respond as a sector to the research that's coming through. Yeah, I think that's my main point.
I think, yeah, go for it.
Yeah, no, that's great. That's
I think you've answered a really hard question, which doesn't necessarily have a clear answer very well in terms of defining that. And you've also touched on the next area that I wanted to kind of steer this conversation, which is about funding, because, you know, we've just kind of highlighted that there are still questions to be answered. There are still understandings and whole areas of the communities and of the HIV epidemic in Australia that we're not getting, you know, people to participate and getting the answers for. And as Martin said, there's a whole realm of people who we're just not getting that data from. So there's work to be done, and important work, and work costs money, because that's what research, you know, it's not done for free necessarily, and everyone needs to earn income, and it also costs money to actually design and disseminate and do the work itself. And John Rule has alluded to this with a really astute question too in the chat. So thanks, John from that one, for putting that in there. It's really about, you know, after 3 decades of different people, pharma, government, state government, Commonwealth government funding research on HIV in Australia, is there still an appetite for that going forward? Where will the funding come from? There's so many competing, you know, health needs or others that compete for limited pool of funding. You know, COVID funding probably would be a priority in the last year over HIV, that's for sure. What do you think, Ben? What do you think is the future or the way forward, or some thoughts on the funding dynamic?
Yeah, it's a tricky one. So I think just to explain, I suppose, where I think for social research or socio-behavioral research in HIV in our sector, where we mostly have got the lion's share of our funding from, has really been 2 places. It's directly from government health departments, and that's usually kind of the policy teams within the government health departments. And then it's from these big research councils that Adam mentioned earlier, like the National Health and Medical Research Council and the Australian Research Council. Now, the way that you get funds from these 2 different approaches is quite different. So the big council approach is that you write up your applications, you are competing with everybody else under the sun who's researching everything, every area of health possible. And so that's where, like you've just said, Chad, you have to then be competing against every other health issue that's out there and trying to make your case. Now, most of the schemes that we apply to under those kinds of funding schemes are sort of like 10% success rates. Sometimes we get up to 20% success rates, but even that's becoming rare. So that's very hard. And then on the flip side, you have the government approach, which is more based, I believe, more on relationships. So you can build really strong, long-term relationships with government departments that then you can sort of get your funding that way through these longer term relationships. It's less about granting schemes and it's more about kind of being aware of what opportunities are there. They got to get some money out the door, they might give it to you, and so on. And then there are some granting schemes, but it's often more about the kind of relationships. So we've been extremely fortunate in the HIV sector in Australia to have been funded really well, as has been mentioned a couple of times. Probably disproportionately to the size of the burden of this particular disease. I'm not saying we shouldn't have got that funding, but if you think about some other areas of health that have much bigger burden on the population, we've actually done pretty well from both of those kinds of strategies. Now, whether this is going to continue is the tricky thing. So I do think the types of socio-behavioral research that is likely to get funded over the next 5 to 10 years has changed, and I think it's going to continue to change. So a few of the points have already been raised. So I think when you're talking to government, it's all about strategy and policy relevant research now. So it all has to be linked back to strategies and policies. And then for the big funding bodies, they're all looking for impact. You have to talk constantly about impact. What impact is your research going to have? So if you want to do some little dinky study that doesn't really have any real impact on the world, it's not going to get funded anymore, even if it has value, both from science and for community. And that's hard, and that can be quite sad. I think biomedical prevention strategies like TASP and PrEP now have to be part of every kind of research project that we do in this space. We can't just talk about kind of sexual cultures or sexual networks or gay community the way that we probably could have got away with in the mid-2000s. And it was completely relevant at that time. And it still is relevant now, but I think it's harder now because I think everything has to be kind of wrapped around getting pills into bodies, which is sort of a little bit unfortunate as well. But there's still a lot of really important social research questions that, say, Martin and others have discussed about what the social research questions that sit around how we do that, how we do that better. So I think biomedical prevention now is absolutely central. I think socio-behavioral research has to be able to show its value right up front in kind of research funding applications and that kind of thing. So for example, we've just got a big extension to the gay community periodic surveys funded. And the way that that got funded is by saying, we're filling gaps. We're filling the, and we've talked, other speakers have already just talked about this. We're filling these really important gaps in the system that we already have, like overseas born people, people who live out of the cities, younger people, those kinds of things. You need to be able to show that you're addressing gaps, otherwise it probably won't get funded. I think there's a few other areas very briefly. So there's a lot of drive around elimination of HIV transmission. So I think things that focus on that will continue to get funded. Implementation research is becoming absolutely central because now we kind of have the tools, we know it works, now we need to understand how to implement it. And a lot of implementation research is social in nature. And stigma. So I think stigma is going to be a new area, or increasing area, it's not new, an increasing area of attracting funding over the next 5 to 10 years. But I will just say, I'm not 100% confident about how much longer the willingness of funders to fund this area of research will last. There's a tricky paradox here, where as we get closer and closer to the pointy end of the epidemic, where there's fewer and fewer sort of diagnoses happen every year, the socio-behavioral, but also clinical and epidemiological research that we need to conduct gets more and more difficult to do and more expensive to do. And we've already talked in the last, Jen gave some a great answer on why some of that might be the case, because you have to do things differently. You can't rely on the same kind of strategies that we've always used, like Grindr, Facebook, and a couple of posters up in some gay venues. You can't do that anymore. You have to think really creatively about how to reach these more marginalized groups of people. So a couple of examples. I don't think it'll be justifiable for much longer to run qualitative interview projects only offering the interviews in English. Now, this is really challenging. I just ran a study over the last couple of years where we did offer in-language interviews. It was super difficult to set up, super difficult to get data quality because we had to train these people that were not actually researchers to kind of be able to do that interview in language. So the data quality absolutely suffered in that. And then when it came to, we got a couple of transcripts, for example, that were transcripts that were verbatim transcriptions of the in-language interview. And we were stuck because the person who'd done the interview was mostly translating most of the interviews, but they couldn't do any more. So we had to go to a professional company. And this cost over $5,000 US to do one interview transcript for a 90-minute interview. Now that is obviously not feasible. going forward. We can't have studies where a single interview costs over, say, 7,000 Australian dollars to actually translate. So we're going to have to do this in more collaboration. We're going to have to work with different partners. I'm not really sure what the models are going to be in the future, but that's just an example of how things can get so expensive so quickly. The other thing is the bit that's already been mentioned about the community connected stuff. So as more community connected gay men get onto ART, tests, get onto PrEP, just a really well connected anything, we're going to have to focus more and more on those people who are less connected. But this can be really hard to do. So for example, if you want to target men who have sex with men international students, for example, a lot of these guys won't be out. A lot of these guys might not even be out to themselves yet because they might have just moved to Australia and they're not particularly open yet. There's a lot of stigma. So to reach this kind of, say, 5% or less of MSM international students, you basically have to target 800,000 international students that exist in Australia at any given time. Now that is massively expensive. How do you actually do that? That's really, really challenging. This is what's in New South Wales. There's a new website that's been set up for international students, the International Student Health Hub. And this is the approach that's being taken there. So it's a general health website. It's not just about sexual health, and it's for all international students, kind of in the hope that the ones that we really care about, which are those kinds of at-risk international students, will hopefully click on the sexual health tab, and maybe they'll read a little bit further down and find out something about where to get tested and maybe where to get PrEP. But you can see the problem here, that as this paradox, that as we get closer to the end, it's going to get more and more expensive and then therefore harder to get the money. So sorry to end on a pessimistic note, but that's where I'll end. Thanks.
Look, I don't think it's pessimistic. I think it's astute, and I think there's some real wisdom in there for, people who may be here tonight who are earlier career researchers or mid-career and wanting that advice from the panel in terms of, well, where should they focus their efforts and their questions. What do they need to do to show impact, to prove that there's going to be value, to focus in the right areas? And that advice is quite profound for them and appreciated. And I thank all the other panelists as well for adding their tidbits in the chat there as advice. I think that's it's useful. As it gets to the pointy end, Ben, you sort of said, disproportionate to the burden. I think the burden's not big because the research has been done well for so long that it's been translated into the policy and practice, which means we don't have the big burden that we otherwise would have had now, 30 years into the epidemic of HIV in Australia, if it hadn't been done so well beforehand. So probably not disproportionate to what we may have ended up with if we didn't put that investment in. So I guess my thoughts there. Speaking of money, Adam, I'm going to finish off with a question for you. If you had money, if someone was going to throw the money at you for an idea, what's one study idea that you would like to get funding for and see up and running at the moment? Carla's got a secret one that she's not going to share with us, but what's yours?
It's as impossible as it's the hardest question ever to answer, because it is not possible to say one. And just having this conversation and hearing some of these questions from the audience has made me think of a bunch of other ones. To be honest, it wasn't. I'm going to be cheeky, Chad, and I'm going to say two different things. I kind of just want to follow on from the amazing comments from Ben and from others, all really linking to the same points about how we engage with the pointy end of the epidemic and those from culturally, linguistically diverse communities, Aboriginal communities, for example. We have a really unfortunate tendency, I think, sometimes to think of Australian-born Anglo-Celtic and then everyone else, as if everyone else are all somehow similar because they're not Australian-born and Anglo-Celtic, right? Like we have a tendency to homogenize everyone who sits outside of the mainstream. The reality is they are infinitely complex, come from 206 different countries, speak 900 different languages, inhabit an innumerate number of cultural groups, and all those different kinds of forces shape their experiences. They shape the way they think about HIV and sexual health. They shape their ability to engage in certain practices and behaviors, how they engage and think about services that they might want to access in relation to their sexual health. So it's so complex to think about how we engage those communities in research going forward. And Jen, actually at the Ashram conference year before last, Jen, I hope you don't mind me saying, like you were making this really great point about saying we're not, we can't do one big study that will understand the needs of all non-Australian born people. It's not possible. We're talking about so many different languages and so many different factors and forces. And what you actually really need is a whole series. You need 20, 30, 40 small projects that are maybe 5 or 10 people at a time, if we can find those people to speak to, the kind of small focused inquiries of people from Myanmar, of people from South Africa, of people from Nigeria, just as an example. The problem is it's almost impossible to find a funder who's willing to sign off on that kind of project. It's not sexy enough. The numbers aren't big enough. Trying to get that over the line with reviewers would be exceptionally challenging. But that really is what we're talking about. So I just need to say that before I said anything else. I guess the idea I had in my head before this conversation all unfolded was actually one about choice. There's so many projects we could do, right? But if you ask me for one, the thing I've been quite interested in for a while is about choice, and particularly empowered choice. So we are at this amazing point in the epidemic where we have available to us right now more mechanisms for preventing the acquisition or transmission of HIV than we have ever had before. We used to rely pretty much just on condoms or on abstaining from sex. Right now, we have more choices available than we've ever had. People can choose to use PrEP. They can attend to the viral load with their partner. They can access PEP if they wish to, and they can still utilize condoms or indeed abstain from sex. And I think we've had a tendency in a lot of the research that we do to examine these in a very unitary kind of way. We look at what are the factors that shape engagement with PrEP and the engagement and uptake and use of PrEP. What are some of the factors and forces that shape how people think about and attend to viral load and negotiate serodiscordance within relationships? What are the factors that inform condom use? Like we have a tendency to look at them in kind of quite unitary ways. If you look at the contraceptive literature, as in pregnancy and contraception, there's a really, really rich and diverse literature about how do people make empowered choices? What are some of the social and cultural forces that shape those choices that they make, the choices that they have available to them? And I think that's something that we haven't done as much of within the HIV field in the last few years, mainly because the choices didn't exist until quite recently. How do we understand how people look across them, what shapes those kinds of decisions that they're making, and how is that process of making those choices, how might that look different for people from Aboriginal communities, people from a multitude of culturally diverse communities, from Anglo-Celtic communities as well. So if I had just one, that's the one I've had in my head for a little while, that's not, yeah, I mean, there's an infinite number of other important things that I think we'd need to consider as well.
Yeah, thanks, Adam. And thanks everyone for your insights tonight. I found this, I knew the discussion would be good when I saw the lineup of the panelists, and I think you've all run true to my expectations. So I want to thank you all for your input. Also to thank all the people who've fired their questions up in the Q&A, and the panelists for diligently addressing those as we go through as well. Some of those questions are not easy things to answer, but I think we've given it the best shot. And I hope tonight has been useful for people from the community who want to learn more about social research and how it works. And if you are from the community and you want to become engaged in social research, there are opportunities through organisations like Thorn Harbour Health that are running this tonight, or the equivalents in whichever jurisdiction you're in, or through NAPWA at a national level. Reach out to those organisations and say, this is of interest to you, because I know researchers are always asking for people who have the time, the energy, the intelligence to, give their thoughts and efforts on a community advisory board or on a research panel or something to help researchers better craft what they're doing so it's more meaningful. So there are opportunities for those of you who are early career researchers joining us tonight. I hope you've found some great insights that will help steer your thinking and direction. And I'm sure the panelists would be more than happy for you to reach out to them, down the track via email and follow up with questions or get that advice that helps you steer your careers in the right way as well. But I've found tonight engaging, and I've learned quite a lot myself. So I hope you all have as well. Did any panelists have a final, very quick word that they wanted to shoot out before we finish up?
Can I just plug HIV Futures 10? hivfutures.org.au. Open now. We're very keen for people to fill in the survey if you've got some. Great. Thank you.
That's the short answer to Adam's question. What do you want funded? My research.
Chad, can I just make one comment?
Sure.
Several people, there was I can't remember who described it as a self-congratulatory back-patting around the role of social research in Australia and what it's been able to accomplish. Maybe as the slightly newer arrival in Australia, as a more recent migrant over here, perhaps I can, perhaps I have greater legitimacy in just really underlining that. I worked in the HIV's field for a decade before moving over here, and I swear to God, all of Europe looks with great sense of jealousy at what was able to be accomplished here in Australia. So many of the really core research studies that really kind of fundamentally reshaped how we thought a lot about sexual practice and HIV related practice. Things like negotiated safety, strategic positioning, like negotiation of serodiscordance, like these all came from Australia. That was in the kind of the scale and the quality of the research that happened here far surpasses what happened in much of the other, certainly English-speaking world. And so I guess I just kind of wanted to kind of really underline that point. And it is a testament to connection between community and researchers. In a UK context, you have, I don't know, 5 different conferences that happen every year. You have the Beaver conference for the doctors, you have the BASH conference for the health advisors, you have the NIVNA conference for the nurses in HIV, you have the social research conference, you have the community educators conference. Almost no mixing across all those different spheres. Australia is really fortunate in having ASHM, where you get 700 or 800 people come together from across all those different communities. It is really, really unique, I think, in the other countries that I've worked in, and I think it's a real strength. And I think that's a big part of why Australia has been so effective in its response, is the nature of that interaction and collaboration.
And only stronger now that we've stolen you over to the side of the world, Adam. Carla, did you have something to say? I saw you went off mute for a second.
I think just to echo that, I went, showing my age, I went to the first ASHM conference, I can't remember if it was 91 or 92 in Wollongong. And, I was very green, very young person, and I was blown away by what I saw. I'd never quite seen it. And as I said, working in other areas of social policy now, it's just not the same. The distance between the researchers, the community, the service providers is vast and lesser for it, really. I think this is a great model to transport to other sectors so they can get the quality, the depth and the application that we've all benefited from whatever sector we're coming from.
Sure. All right, I'd like to finish off this evening, everyone, thanking all of our panelists, but also thanking all of our attendees and for your participation and engagement. I hope you found it very useful. Remember, this is one of a series of discussions on HIV and research in Australia. And the next one will be coming up, I believe, on Wednesday, the 14th of July. So throw that in your diaries, and I'm sure you'll be able to find more details from Thorn Harbour Health from their website. Thanks, everybody. Have a good evening. If you're in lockdown, I hope you're out soon. And otherwise, stay safe. Thank you.